This is part two in the last lecture for the treatment of psychological disorders. Excuse me. In the last set of slides, we discussed the talk therapies of psychoanalysis and client-centered therapy. Both of those try to get clients to have some insight into their underlying disorder and causes, and then the belief is once that insight is in place, improvement can happen. We're going to talk about some different varieties of therapy today, and these varieties of therapy don't rely on insight. They just look to really kind of treat the symptoms. So what the therapies we'll talk about today have in common is regardless of what the cause is, it doesn't really matter, it doesn't need to be discovered. The problems that the individual is experiencing can be dealt with directly. Primary among these is behavior modification. Behavior modification starts with the basic assumption that maladaptive behavior is learned and is therefore changeable. The goal of behavior modification therapy then is to change this behavior, unlearn the maladaptive behaviors, the ones that are not conducive to success or happiness in one's life, and learning new ones in their place. Notice the behavior modification, notice the word learning. All of this is based upon the principles of classical and operant condition, especially those of B.F. Skinner and people who came after him. And the view is that by using reinforcement and punishment, and also the mechanism of extinction, that the maladaptive behaviors can be eliminated. This can be done by reducing the reinforcement for a maladaptive behavior. For example, if someone displays anxiety and receives a lot of sympathy and help and attention, that can actually reinforce the episodes of anxiety. So by looking to see what is motivating the behavior, what's rewarding the behavior, the reinforcement can be changed or some punishment could be introduced. The other task a behavior modification therapists have is to increase desired behaviors, and this can often be done with positive reinforcement. For example, an individual with anxiety, when they display behaviors of reducing that anxiety or dealing with the anxiety in a positive way, could be rewarded with the praise that maybe was formerly rewarding the anxiety. It changed the contingency, so it rewards good behaviors. It could also be rewarded with tokens or points. And this is what a token economy is. Rather than kind of reward the individual with praise or a little treat like we might a dog or a cat, you reward the person with points or something akin to money that they can use down the road to obtain some things. For example, my kid's kindergarten teacher had a treasure box, and every Friday she would open the treasure box and kids would be able to pick a prize. The prizes were just things from the dollar store, nothing very exciting, but when you're a kindergartner, these things are super exciting. What the teacher would do is when there were desired behaviors in the classroom, when kids were sitting quietly, when she noticed them sitting quietly, when she noticed them playing nicely together, when they followed directions, she would give them stickers. And there was a board. Everybody would get a sticker each week under their name. And the more desired behaviors they displayed, the more stickers they got. And if they had enough stickers at the end of the week, they could go to the treasure chest. That's a token economy, where effectively something can take the place of money and reward a desired behavior. Now, the goal of a behavior therapist is to examine the behaviors, look and see what is rewarding it, what's punishing it, what behaviors can be maybe incorporated into the token economy. An example of behavior modification comes from exposure therapy, also called systematic desensitization. With systematic desensitization and exposure therapy, they kind of rely on two things. One is extinction, Extinction is experiencing something without the behavior it's associated with. For example, extinction, if Watson had done it with little Albert, would have involved presenting the white rat, but without the loud noise. Eventually, the fear to the white rat would subside as Albert would learn it no longer is associated with something scary. Systematic desensitization also looks to replace the negative behaviors with positive behaviors. So besides exposing the person to the thing that causes them anxiety or fear, we would also have them learn relaxation techniques, because one cannot be relaxed and anxious at the same time. So these relaxation techniques are not very complicated. They can be learned by anyone. Sometimes they literally are think of your happy place. By imagining a situation or person or place that brings contentment and joy is a form of relaxation. Deep breathing is often commonly taught, and the individual is told whenever they experience anxiety, they should engage in these relaxation techniques. They should then learn to associate the thing that they find fearful or anxiety provoking with relaxation rather than anxiety. Then the therapist would sit down with the client and create what's called an anxiety hierarchy. They would talk out and make a list of things that cause the person anxiety and rank them in terms of how anxious it makes the individual. Here's a sample anxiety hierarchy for someone with social phobia. So this would be created in concert with the therapist. They would sit and talk about different things that cause the individual anxiety and then rank them from 0 to 100 in terms of how bad they are for that individual. And of course, these are not going to be the same for everyone. This is for one particular person. So for this person, having a party and inviting everyone from work was something that caused him the most anxiety. Asking for directions at a gas station here was rated as a 35 out of 100. So that's the thing that was least anxiety provoking. And as you look at all these different examples, you see how the rankings go from high at the top to low at the bottom. So what the therapist would then do is they would start at the bottom and use imagination. Often with systematic desensitization, they start with imagining these situations. Some therapists, exposure therapy, will go right to the actual situation. But in either case, the situation's experienced. So if I was the client, if I was the therapist, I'd say to the client, okay, imagine asking someone for directions at the gas station. Okay, so does that make you feel anxious? Okay, if it does, practice your relaxation. And I would continue to present that stimuli, asking for directions at the gas station, while the client's doing the relaxation until that step, number 10, no longer produced anxiety. Then we tackle number 9. Then we tackle number 8, all the way up to number 1. Right? So what we're doing is step by step increasing the level of anxiety the situations provoke and tying these situations with the new response of relaxation. This has been shown to be very effective at treating phobia as well as anxieties. Cognitive behavioral therapy is a slightly different model of therapy. It relies on behavioral techniques, but also brings in clients' thinking. And the basic assumption is that clients' thinking is distorted, and it's these distortions in thinking, these incorrect ideas about the world and themselves that underlie individuals' problems. Cognitive behavioral therapy has been shown to be effective at treating depression, anxiety, and phobic disorder. The goal of cognitive behavioral therapy is to change the way the clients think, as it's these errors that underlie the disorders. This chart shows some common irrational beliefs, And the cognitive behavioral therapists use the term irrational beliefs because they are beliefs the individual has about themselves that are completely wrong, without basis in fact, yet they're deep seated. And then these irrational beliefs lead to emotional responses. So, for example, this one down here, everyone is watching me, is an irrational belief because someone may think that, but the reality is when one is out in public, there's anonymity in a crowd. There may be lots of people around, but really most people really don't care what the other individuals are up to. But that can lead to social anxiety and embarrassment. So if that's the belief someone has, it's irrational, it's not seated in reality, it can lead to embarrassment and anxiety. Think back to Steve, who was in the clip about depression. He had some negative mindset. He had some thoughts about himself that would fit down here. I'm a loser and will always be a loser. No one will ever love me. And that can lead to sadness and depression. So cognitive behavioral therapist is going to try to work with the individual to unseat these irrational beliefs and ideas. And the idea is that by doing so, the emotional response will change. This could also be mixed in with some behavioral therapy, so some reinforcement. They might give them tasks. If someone thinks they never can be successful, the therapist may give them a task in which they can be successful and give them rewards and praise for when they are successful, to try and not only unseat that irrational belief, but show them that success can happen and is rewarding in its own right. So cognitive behavioral therapists engage in what they call cognitive restructuring, and their goal is to detect these they happen automatically. Someone doesn't have to think about it. They just pop right into their heads. Irrational negative thoughts. For example, I'm not smart enough might be an irrational negative thought that a student may have. The cognitive therapist would then engage in reality testing with the individual by talking to them, asking them questions about their life, and showing them things about their life, provide evidence as how these negative thoughts are false. For example, if a college student said that they were not smart enough, a cognitive behavioral therapist would say, well, no, that's just simply not true. You were admitted to a university. There's evidence you were smart enough. What was your last exam? You passed your last exam? Well, there's evidence you are smart enough. And come up with these undeniable facts from the individual's life to unseat that irrational belief. The goal is to replace these with more rational and adaptive cognitions. Now, the person may not be the smartest person in the room. You don't have to convince them they're the smartest person around. They just need to be shown that they are smart enough, and that's a very different task. Biomedical therapies, and my outline is kind of confusing here. Ignore that one, but biomedical therapies is the final variety of treatment therapy we'll talk about. And again, kind of biomedical therapies aren't talk therapies. They don't rely on discovery of the underlying problem or the root cause, but they're aimed to provide a treatment to deal with the current situation, and that often will result in reducing symptoms. There's a variety of biomedical therapies, but we're just going to focus on pharmacotherapy, which is the use of medication to treat mental and psychological disorders. This has become probably the main mode of treatment in the last 20 or so years, and it's gotten to the point where if you watch television for at least an hour, you probably see advertisements for medications for psychological disorders. There's some out there now for bipolar disorder, for depression, for anxiety, and it has become not only very effective, but I don't say popular, but a commonly used treatment. Now remember, most therapists can't prescribe medications. Only medical doctors can prescribe medications. So a clinical psychologist or a master's level therapist whose clients rely on medication would also have to be working with a medical doctor or psychiatrist. The way these medications work generally is by manipulating neurotransmitter effectiveness. Remember, when we talk about neurotransmitters, and even when we talk about schizophrenia, one of the hallmarks of schizophrenia seems to be an excess of dopamine. Uh, so, by manipulating dopamine in one system, the symptoms of schizophrenia can be lessened. Some of these medications work by increasing the function of the neurotransmitter, some inhibit the function. So the medications for schizophrenia are those that would damp down the effect of dopamine in the individual's brain. We're going to go through a couple classes of these, and there's some brand names there, and I don't expect that anyone would, I'm not going to ask you on the exam what a brand name is, but I put them there because these are common and advertised on television, and they're the way you probably, people are more likely to know the brand name than any other name for the medication. So, if a medication is an antipsychotic, if it's listed as an antipsychotic, it is a class of medications that's used to treat a severe psychological disorder. These might be used to treat schizophrenia, they might be used to treat multiple personality disorder or dissociative disorder, they might be used to treat bipolar disorder. Antipsychotics have been around for quite a while, and their effectiveness in treating these disorders has been noted since the 1950s. Traditional antipsychotics such as Thorazine and Haldol are among this class, and they work by blocking dopamine receptors. They are, if you remember, antagonists. They limit the function of dopamine. What these antipsychotics do is typically relieve the positive symptoms. Now, the positive symptoms of schizophrenia were hallucinations and delusions, and the speech patterns. Doesn't cure the individual, it treats the symptoms. The problem with antipsychotics, though, the traditional antipsychotics, have been that there's side effects, that long use of these medications definitely lead to some negative side effects. And recall from the section on schizophrenia, they don't always work for every individual. New antipsychotics are called atypical antipsychotics or non-traditional because they are new and they work a little bit differently. These atypical or new antipsychotics have been around since the 1990s, and what they do is block both dopamine and another neurotransmitter called serotonin. What these medications do, and their advantage over traditional antipsychotics, is that they relieve both positive and negative symptoms. The negative symptoms, recall, being withdrawal and the rigidity and muscle movement issues that individuals with schizophrenia may have. And they also have the advantage of having fewer side effects. Both classes of these medications are still used because not every individual will respond to every medication. A medication that's an antidepressant or an anti-anxiety drug are those that would treat the anxiety disorders or any of the depressive disorders. Typically, there's very little difference between these two medications, which kind of indicate a similar underlying brain function between these kinds of disorders. Examples of medications in this class include MAO, medications. MAO is monoamine oxidase inhibitors. Monoamine oxidase is an enzyme that breaks down neurotransmitters, which means it's an agonist. It increases the function of the neurotransmitter by getting rid of these enzymes that would otherwise destroy the neurotransmitters. So by inhibiting monoamine oxidase, it increases the amount of neurotransmitter available in the brain. The downside of these MAO class medications is they interact with food and over-the-counter drugs. And if you look at things like decongestants or cold medicines, they'll typically say, do not take this if you're taking an MAO inhibitor, because they do influence the effect of each other, and the interaction is to decrease the effectiveness of each medication. SSRIs are selective serotonin reuptake inhibitors. Serotonin is the neurotransmitter involved, and reuptake is the process at which the neurotransmitter is reabsorbed into the presynaptic neuron. So by blocking reuptake, by inhibiting reuptake, it increases the amount of serotonin available in the synapse. Brand names are Prozac, Celexa, and Paxil. Prozac has been around for quite a while. So by keeping serotonin from being absorbed back, it does relieve the symptoms of depression and anxiety. But Prozac in particular has the side effect of increased suicidal ideation, which is not always present, and sometimes it's just be an increase in that thinking, and an increase in the thinking doesn't necessarily translate into an increase in suicidal acts, but that is a side effect that would need to be closely monitored. Another class of medications for antidepression and for depression and anxiety are benzodiazepines. And these are things like Valium. These are muscle relaxers or mood enhancers. The problem with all these medications is there is a possible side effect of abuse. These are medications that make people feel good, and that medication, anytime a medication has that effect, there is the risk of some kind of abuse. In the last few years, the drug esketamine has become an amazing new treatment for depression. Esketamine is a version of a club drug, ketamine, which is effectively a cat tranquilizer. And it has been abused by people for a while, and only recently has been examined for clinical treatment. And it turns out it is really the first new drug for depression in decades, which makes it quite amazing. And it's especially important because it seems it's helpful for treatment-resistant depression. Remember, the disorders are different for everyone, and not everyone responds to the same treatment. And an individual who doesn't respond to an MAO inhibitor or an SSRI, it seems they might find some relief from their symptoms through esketamine. What esketamine does is trigger the neurotransmitter glutamate. It increases this glutamate production. So it is an agonist for glutamate. And effectively what this does is rewire the brain, and people have experienced a significant reduction in symptoms within 24 hours of taking the medication. The medication is closely taking the medication is closely supervised. It's available now in a nasal spray, but individuals typically have to go to the doctor to receive it. It is still very much experimental, but it seems to be a tremendous breakthrough in treating depression. But it does have this great potential for abuse. And it is really based upon a drug that was abused by individuals. But it does show promise and does show that there's always new medications out there. I want to wrap up the semester with a discussion about the effectiveness of these treatments. Started off saying these are all effective treatments, and all the ones we've talked about are more effective than ones that do not have any evidence. But at the same time, we've talked about treatment resistance, especially with esketamine there. Not everyone responds to treatments, but in general, 80% of treated people do better than the average non-treated person. And that's what this chart is showing. And let me grab a pen here and kind of point that out. The blue curve here is a normal curve, and it shows the outcomes of the number of the average of untreated individuals. The y-axis is the number of people, and down here, poor outcomes are on the left, better outcomes are on the right. So if you see, there's a wide response. If someone is untreated, some people have very poor outcomes. Some have pretty good outcomes. The blue curve covers quite a bit. But the center of the blue curve, right, here's people who experience a lessening or an improvement, right, better outcomes. So effectively, right, without treatment, half of all untreated people will experience a better outcome. That's just the nature of statistics. The red curve, though, demonstrates the average psychotherapy client. Notice in general how the red curve is shifted to the right, right? People in treatment tend to experience better outcomes than people who are not treated. But not everyone who gets treated experiences a good outcome. The red curve extends down here. But if we look from the center, right, the center of the blue curve is 80% of the red curve. And that's where the statistic comes from. It seems with treatment, people have a much, much better chance of a good outcome than without treatment. So are they effective? Drug therapies in particular, everyone believes they're effective. It is a go-to medication. Drugs are easier to get really than psychotherapy. You can go to your primary care physician and that individual can prescribe a Valium or antidepressant and give you a prescription and send you on your way. Drug therapies, I think, are definitely needed for very severe disorders such as schizophrenia and bipolar. A talk therapy, a behavior therapy is can only possibly be effective if an individual is coherent and lucid. And an individual who's in a manic phase, an individual who is perhaps severely depressed, or an individual who's experiencing hallucinations and delusions is not going to have a good outcome from a talk therapy. So it seems they're especially needed for severe disorders. With things like anxiety or depression, though, psychotherapy alone is often just as effective. And this is often surprising to people that a talk therapy, some kind of psychotherapy, is just as effective as a medication. We tend to think of medications as these miracle cures. This chart shows the result of a study that had cognitive behavioral therapy, imipramine, whatever that says, imipramine, which is a medication, placebo. Now, placebo is a fake medication. And then this final bar, move my marker there, is combining what happens when cognitive behavioral therapy is combined with medication. The y-axis is percentage of patients with a reduction in panic disorder symptoms. So this is a randomized clinical trial. It means individuals with panic disorder were asked if they wanted to be in a study, and they were randomly assigned to one of these four conditions. Psychotherapy alone, drug alone, drug and psychotherapy combined, or placebo. They thought they were getting medication, but it was an inert substance. Notice, right, 37% experience a reduction in symptoms when they took a sugar pill. This is the standard, right? A placebo group is the standard for a treatment. A treatment should work better than effectively doing nothing. A placebo group is good, though, because those individuals think they're being treated. And both imipramine, the drug, and cognitive behavioral therapy are above placebo. But if you examine it, you see cognitive behavioral therapy leads to better outcomes than the drug alone. But the best outcome was when the medication was combined with the psychotherapy. And I think that is the standard of treatment for most disorders. Some kind of combination of medication and psychotherapy. That would seem to happen because medications don't teach coping skills, right? The medications can relieve symptoms, but the medications don't tell someone how they should approach new situations. It doesn't give them confidence for dealing with things that might cause them anxiety. It simply makes the anxiety go away. Well, these things can happen with psychotherapy alone, but with medications, it can even facilitate the effects of psychotherapy. So the important thing to remember, that with an individual with a disorder, they've lived with that disorder a long time, and they've learned how to get by uh, with the disorder. And just having a medication, even if it removes the disorder, doesn't necessarily help them to change their behavior patterns that resulted as a way of coping with the disorder. So it seems the best use of medications are if a severe dysfunction exists, then absolutely medications are useful, and either in combination or when psychotherapy alone is ineffective. And it seems when someone has a severe disorder, some combination of the two is important. The point in that slide about, I want to go a little bit further, the point in there about the placebo effect. And even in the other chart, remember, half of all untreated people tend to have a better outcome. It seems that treatment isn't always effective, and it is true that someone who is untreated can get well. That's also true with medical disorders. Individuals can have cancer and not know it, and the cancer resolves itself. There's individuals who've had coronavirus who didn't know it, and it was a mild case and it resolved itself. So we are capable of, and some disorders go away, and we are capable of kind of doing that without seeking any kind of psychotherapy. But as you saw, psychotherapy tends to increase the likelihood of a good outcome. So let's talk about some treatment illusions. Sometimes people seem to do better, and it's not so much because of the therapy, but because of something else